Good evening, everyone. I'm Dr. Rituparna here. I'm going to speak about anesthesia management in children with ingested alkaline batteries. Starting with the patient profile, 1 year, 5-month-old female child weighing 12 kgs. The mother noticed the child playing with toys and later putting a shiny object into her mouth. She soon realized that it was not a toy battery and brought the child immediately to the hospital. The child was absolutely asymptomatic on presentation. On examination, no other abnormality detected. So we had asked for an X-ray PA view of neck, chest, including the abdomen, and a complete blood count. Findings were a button battery was seen in the upper esophagus as double ring or halo sign. In lateral X-ray view, it was appeared as a step of appearance. Coming to the preoperative evaluation, NPO status was confirmed, IV access was checked, informed written consent was taken. For anxiolysis, 0.1 mg per kg midazolam was given. Intraoperative management, ASA standard monitors were connected. Induction was done with injection propofol 3 mg per kg, injection fentanyl 2 mics per kg, and injection atracurium 0.5 mg per kg. Airway was secured with a downsized micrograph ET tube and was continued with control mechanical ventilation. Anesthesia was maintained with O2 air and sevoflurane. For the procedure, neck was positioned with extension for rigid esophagoscopy, and the foreign body was removed successfully. Esophageal sloughs were noted. After the procedure, the child was reversed and extubated and shifted to the post-operative room. Because the procedure went uneventful, the child was discharged within 2 days and was asked to come for follow-up after 2 weeks. Surprisingly, the child came after 2 weeks with a history of choking, and it was noted to have a tracheoesophageal fistula on upper GI endoscopy. Here is a short video of the child with the complication. So we can see the foreign body here in the upper part of the esophagus. So here in the bronchoscopy, we can see the tracheoesophageal fistula in the posterior wall of the trachea. Then we go ahead with the esophagoscopy. And we can see the damaged esophagus and the tracheoesophageal fistula with our ET tube. So coming to the introduction, the growing presence of domestic electronic equipment has led to an increase in button battery ingestion in the pediatric population. The highest is seen in children less than 6 years old and the peak incidence at 1 year of age. Coming to the mechanism of injury, so what is a battery? A battery is a series of electrochemical cells in which a chemical reaction generates a potential difference and drives the charged particles to flow through the medium, thereby producing an electric current that causes pressure necrosis, corrosive damage, heavy metal toxicity, and direct electrical discharge. The most common site of injury is upper esophageal fistula, upper esophageal sphincter, that can lead to tracheoesophageal fistula or vocal cord injuries. The second most common site is aortic crossover and main bronchus, which can lead to aortoesophageal fistulas, and the least common site is lower esophageal sphincter. So, if it's a witnessed ingestion, the child usually presents with drooling, coughing, stridor, shortness of breath, vomiting, difficulty in swallowing, or a painful swallowing. If it's an unwitnessed ingestion, usually the child presents uh, later and usually presents with the complications like hemoptysis, chest pain, cough, stridor, hoarseness, sore throat, hematemesis, melena, abdominal pain, etc. So the severity of the button battery injury depends on the size of the battery, the age of the child, the type of metal, the site of impaction, the duration, and the voltage the battery is carrying. So we have already discussed about the imaging in my previous slide. If the child presents with complication, a CT scan or an MRI can be considered. So coming to the management, if it's a delayed removal, surgical intervention and a CT should be considered. If it's within 12 hours and endoscopy is available, we should go ahead with that. If endoscopy is not available immediately, mother is advised to give the child honey or sucralfate. If the foreign body is in the small intestine or colon and the child is symptomatic, then we should consult the surgeons. If the child is not symptomatic, we can do a repeat x-ray and check whether the battery has been passed off naturally. If it's in the stomach and if it is within 12 hours and the child is symptomatic, then we should consider endoscopic removal. If the child is not symptomatic, we can repeat x-ray after 7 to 4 days and see whether it has been passed on naturally. Anesthetic considerations: extraction is urgent. Do not wait for the symptoms. Goal is removal within 2 hours. Do not delay for NPO time. Patients may have received honey or sucralfate to minimize the tissue damage. Consider appropriate staff, equipment, and location for the battery removal. Assess risk factors like bleeding. So prepare the OT accordingly. Patient may require inpatient monitoring and repeated procedures. So we'll discuss the role of RSI in children. Usually the classical RSI that we practice in adults is not visible for pediatric population. So what we usually practice is a modified RSI where we practice gentle mechanical ventilation where the PEEP is kept as not more than 10 centimeters of H2O. If there is a nasogastric tube already there, we should consider suctioning and leaving it open to the air. A little head up tilt can be considered in older children, and we should always avoid a precoid pressure. Thank you.